But first, can you just feel free to have questions? Please use the microphone. It's much better to go. For online questions, I'm going to try to see any questions too. Dr. Norman Gitlin, you know him very well too. He's our great senior hepatologist here locally. He is a former professor of medicine and the chief of hepatology at Emory University. He's now practicing in South Orange County, part of UCSD program. He is a fellow of ACG, ASD, and he's also a fellow of Royal College of Physicians in both Edinburgh and London. He is actually the chief of clinicals in liver disease, very good review series. And he has participated in many clinical trials from hepatitis B, C, and now NASH too. Dr. Steven-Huy, you know him very well too. He's a UCLA professor of medicine. He's now the Philip Palombo professor, endowed professor. I hope I pronounced right. And he's also a program director for the hepatology program over there. He also has like more than 60 pages of CV, but we know him very well. He's a very active clinical investigator and educator, giving us talk nationally, of course, our society too, and internationally too. And he is very actively involved in this society too. So let's open the Q&A session.
Can I start with a question?
Yes, Sammy, yes, of course.
So I think the biggest seller for us is fatty liver right now. And I have a question. How should we be screening our people for fatty liver? Well, not us. How should the primary care doctor? Oh, sorry, thank you. Thank you. So what should we be telling our primary doctor and chronologist in terms of how do we screen for fatty liver and how good are those tests?
Yeah, I think right now as we're on the cusp of emerging therapies, education of our primary doctors is important. What I tell my primary doctors is, first of all, the recognition with the risk factors. You know, 3 or more metabolic risk factors, diabetes in particular, age over 50 or a first-degree family member with NAFLD or cirrhosis is already a high-risk individual. So you can get it based on clinical predictors of high risk, but then I encourage them in that clinical phenotype to do a FIB-4, and if it's higher than 2.67 to refer a patient on to a FibroScan, so dual modalities, with the intention that we at more secondary or tertiary medical centers are seeing not the simple fat with zero fibrosis. We don't want to see those patients. They can be retained in primary care for diet and exercise, physical training. We want to see those patients with, bad NASH, the enriched patients with steatohepatitis and at least stage 2 fibrosis, because I suspect these therapies, when they do become available, will be managed and the prescribers will be more liver hepatology prescribers, at least at the onset. So I would encourage the education with a recent AASLD guidance that came out that really details care pathways and risk stratification modalities using clinical predictors coupled with a FIB-4, and if indeterminate or high risk, referral on to transient TLAS.
Dr. Gitlin has some comment?
Yes, thank you very much. I'd like to thank the organizers for inviting me. The first thing I'd like to say, don't forget that fatty liver is associated with the metabolic syndrome. And we've done an analysis. About 70% have diabetes, 66% have hyperlipidemia, 60% of hypertension, coronary artery disease, sleep apnea, and in women, believe it or not, polycystic ovaries. Very, very common in women with polycystic ovaries. So I was very lucky to be trained in London under the late Dame Professor Sheila Sherlock, and she always used to say, have a high index of suspicion. And sometimes you can make an easy diagnosis, just an ultrasound of the abdomen, increased echogenicity, and a fatty liver is almost 90% going to be guaranteed of your diagnosis. So be aware of these particular factors, and remember the metabolic syndrome is very important. Thank you.
I do have to say, I think we need better tests. I think like 18% of people with low FIB4s could actually have significant fibrosis.
So these non-invasive markers, whether they be imaging or serum-based, perform exceptionally well for their negative predictive value. So they are really good for excluding those that we don't need to worry about, especially if the FIB4 is less than 1.3. You could be pretty confident that there's absence. Or the transient elastography is less than 7. You could be pretty confident with 90% confidence for negative predictive value that there's absence of disease. But that does leave about a 10 to 12% miss rate. So if there's concern based on clinical risk factors or elevated liver aminotransferases, then you have to couple that with your clinical acumen.
In LA, about 40% population is Latino, Hispanic, and they're overrepresented with fatty liver. So we did a study looking at the accuracy of FIB4 in Latinos, and we found that when there's diabetes present, that the FIB4 thresholds, as we know, are not very good.
Where FIB4 loses some of its sensitivity and specificity is when the age is over 65, because age is weighted into the algorithm and may lose some of its specificity.
Yeah, one way of approaching this is sometimes when we're looking at the geriatric population is to cap it at 65. Regardless of whether it's 70, 80, whatever, the maximum age you can be at 65. And then, not surprisingly, the platelet count becomes the most important determinant factor here, which is what you'd expect.
But while we're talking about that, if you're doing a fibroscan, if the patient's body mass index is over 35, be wary of overdiagnosing F4. Very bad mistake. We don't do it when the body mass index is more than 35. Thank you.
We've also been seeing a lot of Asians with fatty liver who don't have the metabolic syndrome. So if you have any patients, any suspicion for anything going on, abnormal liver tests or anything, I agree with Norm to get the ultrasound.
Do we know why there's difference in certain population, like people from Asia, where they have a different cutoff for BMI to define obesity?
I don't think we understand that.
Yes.
Okay, so exciting talk about fatty liver, but my question is for you, Jasmohan, about could you comment on procalcitonin, because that has been a common test ordered by anybody who comes with a concern of sepsis in the hospital. It's just mainly because it's been used, so I just wanted you to comment on it. And the second question is ammonia coming back, especially as a fertility marker in patients who are very, very sick with acute and chronic liver failure? I know we worked very hard to tell people not to check ammonia, but I just wanted to see what are your comments on those two things?
I've got to answer that question. I mean, ammonia only benefits the laboratory that's performing it. They love charging for it. There is absolutely no benefit in doing ammonia. Every day doctors phone me with the ammonia. Unless you're taking it fasting, resting, arterial, and immediately on ice, ammonia test is not worth the paper it's on. And please do not waste your time or money and do ammonia. If you want to do something, just do this, hysterexis. Tell the patient, if they show a flap, that's good enough. But a number of times people get ammonia 100, 200, and tell me patients in gross coma, the next day they've woken up and it's still 200 because the ammonia is a total waste of time. Sorry to hug the question.
No,
Yeah,
I totally agree.
Yeah, the question about ammonia is in the futility score when somebody's in the ICU with multi-organ failure. But can you comment on the procalcitonin?
No, now that you've triggered me with the ammonia, I see that.
Okay.
It's again, I completely echo Dr. Gitlin's thoughts. But remember, we also talked about acute liver failure, where the liver was normal, something bad happened. In that, ammonia is actually very useful.
Yes.
For neurological, but not in acute and chronic liver failure, not in hepatic encephalopathy, not even in outpatients. And it's not because there's no inherent value in checking it, it's just that there are so many factors that go into actually making it the perfect measurement that we lack. And we lack the discipline to do it. And ideally, in addition to what Dr. Gitlin said, an ammonia that has to be drawn without a tourniquet. Have you ever heard of anyone, any phlebotomist drawing things from not an IV that is not a tourniquet? That's just automatically increases the ammonia level. So that's ammonia levels, even in the extremists, apart from acute liver failure or in people with urea cycle disorders. Those are the only two places where you would actually find them to be of any use. And there is no prognostic value even in higher, lower stages. Procalcitonin is very muddy. It's very muddy. It's higher in people with cirrhosis, even when they are walking, talking, doing everything. And it's higher in people. Doesn't have that much of an oomph that we thought that it had. And in patients with cirrhosis, it becomes even more challenging given that a lot of the liver failure actually can increase the procalcitonin. So unfortunately, right now, there is no AHA test for sepsis beyond a high index of suspicion and making sure that you do the cultures before you start the broadest spectrum possible of antibiotics and narrow it down. It's amazing, given the fragmentation of care that we have right now with hospitalists, internists, our outpatient staff, our inpatient staff, that we fail to communicate with each other what cultures are still pending, what is not, and the house staff team changes. No one follows the culture that was drawn 3 days ago. And now that shows that the culture, this was now easily controllable with a much narrower spectrum antibiotic. No one involves ID early unless the patient is dying. So you want to actually do all of these things right up front, which these sound very boring. There's not exciting, there's no stress, but these are what actually end up saving lives in most cases. And I totally empathize with you. I wish we had a better test to say, yes, this patient has sepsis, and no, this patient does not have sepsis, especially in the setting of cirrhosis, where the SIRS criteria are automatically fulfilled in most patients just because they have end-stage liver disease.
And Sammy, what is the use of cystatin as a kidney biomarker for patients? I mean, I know we talked about creatinine, but my nephrology colleagues are really shying away from creatinine now, especially when you don't have enough muscle mass. And so what are the thoughts about?
And great question. It's a better biomarker of kidney function, but but we don't have a lot of data how it works in our daily lives. How we use it in people with cirrhosis, with acute kidney injury. So we need more data. But that's only one of many urine and serum biomarkers that are emerging. But we just need more data on those.
I think NGAL is the other one. NGAL is the other one.
Yeah, that looks more promising.
Yeah, but both of them are, one is the tubular marker, the other one is, the other marker. And this, you want to actually have a setting, if you have the ability to run them, not all of them are commercially available. So if the capability of doing all of that, that can take the race out of the equation, that can take the muscle out of the equation. So that's much more where you have a little more time to think. When, as you know, is the cases that all of us presented in the inpatients, we don't have time to sit and think. You just have to do things right off the bat and do things. NGAL has capability to distinguish ATN from HRS. So that's the big utility in that. So that's where I think even in very sick inpatients, it has some utility. So I think if you have the capability of getting that, that would be my preference. Cystatin C is just basically a much, much better, much more specific creatinine, but it won't tell you where this is coming from, to my knowledge at least.
Good. Next one, second microphone.
Thank you. My name is Melanie Hunt. I'm an incoming third-year GI fellow and combined transplant hepatology fellow at USC. Thank you all for coming and speaking. My question is also for Dr. Bajaj. You mentioned the appropriate use of PPIs, which is a huge topic with a lot of new research coming out. My question is, in patients who are undergoing the prophylactic banding pathways, often I've seen people use PPIs to prevent post-banding ulcers, and others don't recommend that. So I'm curious your comments and your practice.
So I tend to use less. Same with PPI and same with primary prophylaxis for SBP. These are the two things that in my practice, I don't use at all. In our clinical settings, we usually rely majority on carvedilol. And now, as you know, you don't even have to wait till they form varices to actually start them on carvedilol. So the amount of prophylactic banding that we have, for primary prophylaxis has gone down very, very much. Now, secondary prophylaxis, that's a big open question. At this stage, I tend not to use PPI. And in fact, in people who come in with upper GI bleeding with cirrhosis, and at that time, you first throw the kitchen sink at them. It's like the same broad spectrum to narrow spectrum. You go and you do an endoscopy and there is no ulcer, there is nothing else that's going on. the PPI needs to be stopped before that patient leaves the hospital, because there is no good evidence that this banding ulcer is going to be preventable by this, because it's a physical improvement. So when as you know, when the varices burst, it's a physical thing. It's just pressure becomes too high and it bursts. It's not a coagulation thing. It's not acid lapping at it, making it weak. And same thing with the banding ulcer. It's an ulcer formed because of that band falling off. So there is no hypothetical, even as the pathophysiological mechanism by lowering the acid, which should do that. So that's why in my practice, I don't routinely do it, but I get your point. Many of my colleagues do, despite my telling them. But it's very hard to stop a PPI once started. Same with lactulose, very hard to stop it once someone has prescribed it.
Thank you.
Yeah, Frank, yeah.
A couple of questions. Following up with the discussion regarding the procalcitonin, what about the lactate? You know, the same thing happens, you know, with all the hospitalists. As soon as we get the consultation, the elevated lactic acid, procalcitonin is elevated. Where do we go from there? Second question is going to be for Sammy, but.
So lactate is a very important thing, and I think it is much more useful. Again, won't tell you whether it's sepsis related or not. It just tells you that there's overall badness. There's been studied that MELD lactate is better than MELD alone. We've also validated that in our multi-center cohort. So yes, if the patient is sick enough, please follow the lactate. It is actually much more important. But again, the question initially was whether procalcitonin is a marker of sepsis. And lactate, again, is not a marker of sepsis, as you know. It's just a marker of hypoxia in the body, just generalized shock or lack of perfusion, adequate perfusion. So yes, it's good for following the outcomes, but it won't tell you why that outcome is happening beyond the other.
But it's a bad prognostic sign, depending on the level of lactate. I mean, it could be a catastrophe, perforation, bad sepsis, but lactose are very, very, we get worried.
So Sammy, octreotide versus terlipressin, do you ever use them combined in cases where?
So in the clinical trial, a lot of patients were first on octreotide and Midrin, they switch over to terlipressin. Our standard now of care at our institution is start with terlipressin, unless you can't for some reason, creatinine is very high, their post-ox is low, but terlipressin alone.
Do you use Norapi?
No, we do not.
No.
No.
Thank you.
Thank you.
Just a mundane comment about SPP identification. I continually find in my community hospitals that the PA in interventional radiology is doing your paracentesis because you're too busy or can't get there and get activated. They just send it off to the lab rather than inoculating it in a blood culture bottle. And I continually fight that. And I think you have to remind your ER docs, your interventional radiology teams in general, for that simple thing to increase your recovery rate.
That's happening
20%.
right now. We're
Pardon?
getting tons of positive, unnecessarily.
But we've known it for 40 years.
We're seeing that right now.
Yeah, education, I think the more education you have, the more, and you need, unfortunately, if you have a patient with a bad outcome, you need to actually do a root cause analysis and say, and the bad outcome might be this patient got a resistant infection because that you start them on antibiotics that were completely unnecessary 2 months down the road that the IR people never see. Now this patient, so if you have certain cases like this in which you present it as a quality improvement and a root cause analysis and you all sit together, that in my things, we finally got a set where we have that these are the sets of orders we need from you for this particular patient, and they usually follow. But it took a lot, like you said, took a lot of back and forth and talking to, and until finally we've reached kind of a, I won't say a stalemate, but at least an understanding. Yeah, you need to keep on reminding because, IR is doing 5 million things. We are doing our thing only. So I think we need to, the more we remind, and our IR group has a nurse practitioner now that they've actually done, who's much more responsive because she usually puts everything together and actually has a packet for each and every patient, especially the patients that they keep on doing taps on the time. So I think if you have that 1 point person rather than 3 or 4 people, that actually to remind whoever is doing the procedure, that is much more useful.
And one other thing that to follow up on Chuck is There's absolutely no reason not to do a diagnostic tap. It should actually be part of the physical exam. PT, platelet count, no excuse not to stick a needle in there and get a little bit of fluid to send. And I agree with you completely. You have to inoculate the bottles right at the bedside. Bruce Runyon taught us that from day one, and it's the only way to get a positive result.
Dr. Gitlin? Yeah.
One of the prolonged complications of the COVID epidemic has been alcoholism. I have never in my life, 40% of all the patients I'm seeing are NASH, and the other 40% are alcohol, and women are knocking down the door with alcoholism. And I think, I don't know if it was the frustration of the face masks or what it was, the homeless, but I must make you be aware that alcoholism is now paralleling NASH as one of the commonest referrals I see. While I've got the microphone, please do not forget hepatitis C. There's still 2.4 million Americans with untreated hepatitis C, and when patients get referred to me, they invariably don't turn up for their appointment. We phone them for a second appointment, they get a second appointment, they invariably don't come, and many of them, 50%, don't even come for their third appointment. We can cure hepatitis C in 8 to 12 weeks with a simple medication, no side effects, and it's just a crying shame that 2.4 million Americans have still got this disease. The biggest problem, most of them are asymptomatic.
Can I put a plug for hepatitis B? Because as of, I think, March or April, the CDC recommends routine screening of all adults for hepatitis B as well.
Great, okay. Kevin?
Yes, two questions. Basically, just question on the clinical practice from all the people on the panel. So just a quick clinical scenario. Patient with fatty liver, ALT was above 100. Talk to the patient in the clinic. My mouth was running too fast. I started talking about some of the upcoming drugs, and one of them was the GLP agonist. And lo and behold, on the news, people read about Ozempic and the two cousin drugs. Then came to my clinic and discussed about it, and now she wants it. So I talked to endocrine, talked to PCP, got the runaround. Nobody want to start a patient on Ozempic. There is a patient not just with fatty liver, but also metabolic syndrome with diabetes, was only on metformin, hemoglobin A1C between 6.5 and 7. So now I end up prescribing Ozempic for 2 of my patients now. But as you know, the dose that they use for diabetes is different than the dose that they use for the trial. So I'm starting at 1.25 Q weekly right now. Potentially I can go up to 0.5 weekly. I don't have the gut to go all the way up to 0.1 daily as the trial. Do any of you on the panel actually prescribe the drugs, and how you actually approach this?
Well, I'm going to say the hepatologists are not allowed to prescribe the drug. The insurance companies won't accept it when I try and prescribe. But what I do is, as the patients have the metabolic syndrome with diabetes, I gladly refer them to an endocrinologist who often says, what about the drug? And I say, wonderful. That's the back door to getting them the drug. And the weight loss alone improves the diabetes. It's definitely good for the NASH. And that's the way I go about it. Thank you.
Yeah, I go about it in prescribing GLP-1 for the FDA-approved indication for use. So when patients have an indication for obesity, to use Ozempic, whether it's Wegovy or not, at the approved indications for weight loss or diabetes. I have been able to prescribe it as a hepatologist, but most of the time I will work with my endocrinologist. I am not prescribing it specifically for the indication of NASH as of yet, although I do talk to my patients about the associated benefit potentially of weight loss and improvement in diabetes on the NASH, and the two can go hand in hand. So the problem is, it's 40% of patients will have some of the GI intolerances as you escalate that dose. And the out-of-pocket costs can be substantial for some of our patients. So the ability to sustain it, depending on copays, can be hard. So it's not uncommon that I find patients start and stop and say, I can't afford this anymore, or those that have some GI intolerances. So I try to optimize their metabolic drivers as much as possible: diet, exercise, nutritionist, treating lipids with a statin or metformin or any other, SGLT2s or so forth. And if they're refractory to those things and need help with weight loss or glycemic control, yes, GLP-1s are approved for those indications, and I do use them.
So I've treated a handful of patients, but something I learned from our talk is that right in 2023, right now, treatment of NASH is very tailored. You deal with the underlying problem, like you said, because fatty liver is very heterogeneous. You can have metabolic risk factor, genetic risk factor we never talk about, environmental risk factors, and so giving someone who's got semaglutide who has a genetic reason won't do anything. So I think what you said is very true.
To Dr. Gitlin's point, I often look for, my general thing, look for any and every potential metabolic driver. And I routinely screen my patients for sleep apnea, and 90% of the time I find it, particularly in unique ethnic cohorts, Hispanics, Asians. They are more prone to potentially, just because of their facial structure and more narrow airways, due to ethnic variations alone, for sleep apnea, and patients don't even know they have it. And correcting each and every metabolic driver, I do lipids, I do glucose, I screen for sleep apnea, I screen for PCOS in my young women. So part of it, and there is data that treating each and every metabolic risk factor, improving glycemic control alone may improve liver aminotransferases. and risk
What
of
about
fibrosis.
psoriasis? There's
Psoriasis?
a connection between psoriasis and fatty liver as well. It's a
Yeah,
big
there's
one.
a connection
Yes,
between psoriasis and fatty liver.
But
and
they're
there's-
already usually diagnosed
Yeah.
at that point. But it's not like we
Yeah.
are diagnosing psoriasis, but they've actually found that as well.
Yeah,
Not that we'll correct it at this point. To answer your question, I send all of mine to endocrinology, or they're already on endocrinologists. Right now, I don't prescribe anything for NAFLD associated GLP-1. And this field is going to get much clearer sooner rather than later, hopefully, for the GLP-1 agonist.
Please don't forget that obesity is not a prerequisite for fatty liver. 10% of my patients are as lean as anyone in this room, so be aware of that particular point. Obesity is not a prerequisite. Thank you.
Yeah,
And-
we're almost
oh,
running time. Just a short question. First microphone.
I have a question, Dr. Hu.
Kevin, please, we have so many questions. Sorry.
Okay,
Yeah,
thank you.
you please. Short question.
Would you slip in an MRI and elastography, even though you're not going to prescribe the drug, so you get a baseline so you can prove something downstream? I don't know. It's $600 here, so it's relatively inexpensive.
In the absence of approved drugs, my primary indication for MR elastography or risk stratification is to find those patients with advanced hepatic fibrosis, F3, F4. And the reason for that is we still have an obligation for monitoring these folks for hepatocellular cancer screening. And when the platelet count is low, which sometimes our primary care doctors lose sight of, we have to apply Bovino criteria for consideration of screening for esophageal varices. So in the absence of a liver-directed pharmacotherapy, my primary goal is risk stratification to tease out those patients with advanced hepatic fibrosis, because we still are obliged for surveillance and monitoring MELD score assessments, and just guidance on even the avoidance of sarcopenia and high protein diets and so forth.
Now, one related question, online attendees. Can you comment on workup for NASH, including when a fiber scan is needed?
So the workup for NASH still applies for the workup of asymptomatic elevation of liver enzymes, or even the evaluation of fat on an ultrasound. This will be renamed metabolic associated steatosis. There will be a paper upcoming in Hepatology redefining the nomenclature for this disease and associating more with metabolism. However, obese people get Hep C. They also could have Hep B. They could also be surreptitious alcohol use. We have to do our due diligence to exclude competing diagnoses, because our management approach may be different if those competing diagnoses exist. Even hemochromatosis is very common, and it's not infrequent that I see overlap syndromes of alcohol with metabolic syndrome, iron overload with metabolic syndrome. So the evaluation for chronic liver disease applies, and when you're really only left with metabolism as a driving root cause, going down the appropriate pathway for that, I will do fiber scans in anybody in FIB4s at risk or for whom I find hepatic steatosis on ultrasound or chronic elevation of liver aminotransferases, or patients at high risk for fibrosis, such as those with diabetes.
This is a very active panel and audience group. I didn't have time to ask questions. I have to ask one. Sorry about that. Yeah, so talk about liver hepatorenal syndrome. So maybe question for Sammy or the panel too. You give us nice view. Now we know more variables or like early treating, not treating really severe acute necrotic liver failure. But you also touched the balance of treatment versus mild priority. But you didn't give us your comment. You just reached the question. Can you give us a comment on that?
On treating hepatorenal syndrome with people with high
The
MELD scores?
priority, you want to go keep a high MELD score for transplant, or you treat it right now?
So if we have a patient who we think is very high on the transplant list, is going to get transplanted in the next like 2 to 4 weeks, we're not going to use terlipressin. But it's all you can, and those people are probably very sick as it is. They're going to have a high creatinine level, they're going to have a high LCF score. So they will actually be hurt by terlipressin. So we would not, if someone's mitigant transplantation, there's no point to it.
Thank you. Another question I wanted to know that too, partner here too, Sammy, your UCLA program too. We are right now allowing hepatologists prescribe inpatient terlipressin. Now nephrologists are trying to involve it too. What's your practice or other programs too?
So at UCLA, we've had a problem where nephrologists were a little too aggressive using terlipressin and inappropriately. So to get approved at UCLA on a ward patient, they have to be approved by both renal and liver.
Most teams.
Yeah, not renal alone.
In our case, it's kind of a mixed bag between the two. And our problem is our nephrologists very rarely diagnose HRS. They usually are like, this is unlikely to be HRS. I said, how do you know that? You've not done this, blah, blah, blah. And then, so we try to ask the teams not to consult nephrology.
Yeah,
if it's a GI patient, please do not consult nephrology or neurology.
So
these are the two specialties that may not add anything. If a patient is encephalopathic, they do everything, and then they say metabolic encephalopathy. Oh, well, thank you so much. I knew that already.
So we have the opposite. Our nephrologist diagnoses everybody with HRS.
Oh my God,
Yeah,
please do not export them.
Yeah.
Okay, so I think it's time to wrap up the session and the program symposium too. So on behalf of SCSG